So I'm going to talk about hair loss. Again, this is a good subject, not only because of your patients, but in self-defense. No conflict of interest. And, you know, hair is a huge problem, a huge subject. And so what I've chosen to concentrate on, because I can kind of get through this, not really, but I'll try my best, is the person who complains of hair loss. And I'm going to limit it to the adult, except for Tinea Capitis. It's uncommon in adults, so I'm going to primarily discuss children there. But the topic is, I'm losing my hair, what's going on, and what can you all do about it? So this is supposed to be a joke. You know, sometimes I show this slide and no one laughs. So I'd appreciate a hearty round of laughter. Loss of hair makes you blue. There you go, the blue men. So hair grows, and it's a cyclical thing. It grows for a while, that's usually years, and then it rests, and then a new hair grows, and the new hair pushes the old hair out, and that's why every single person loses hair every single day. So you have to distinguish between normal hair loss and pathologic hair loss. And normally, we lose about 50 to 100 hairs a day. It's not only cyclical in terms of the way the hair grows, it's also climate related in this sense. November and December are the highest hair loss months of the year in North America. I think it's the stress of having to deal with your children and relatives at Thanksgiving and Christmas. That's what I think, but you know, it's November and December. Hair loss is the lowest, usually, in the summer months. Nails grow quicker in the summer months, by the way. So hair cycles, that's the basic. Now, hair falling out. Let me just briefly go over what you can do, and then we're going to talk about diseases. Look at the scalp. You know, sometimes you see people who say, my hair's falling out, and you look at them and you say, what? You have 1 billion hairs there. There's no bald spots. There's nothing. They're crazy. And they are. That's just it. If there is hair loss, try and at the sort of the broad picture. Are there patches of hair loss? Or is it sort of just all thinning? Because that puts you in different categories of disease. Yank on some hair. I love to do this when they're talking about hair loss, so I'm going to take a few more out for you. Take what you can grab between the thumb and forefinger and just sort of yank. See if anything comes out. Another thing in people women, you really can't do this in men too much, who have long hair, you have them take their hands like this and just run through the hair and see if anything comes out. If there are certain kinds of hair loss, and we'll talk about these in a second, if there are certain kind of hair loss, if you grab a bunch of hair and you pull, you get 25 hairs. That's a real ominous thing. On the other hand, if you pull and you get absolutely nothing, and you do that in 4 or 5 spots, and they look like they have normal hair, break out the psychotropic drugs. Okay, collect hair. I think this is cool. You tell the patient to go home, so that if they have hair on the bottom of their shower, take it away, clean off their brushes or combs, whatever they use to groom their hair, and then every day collect the hair that's on the bottom of the shower or on the bottom of the tub, out of the brush, out of the comb, put it in a baggie, label the day, and do it for 7 days in a row. The reason I do this is for two purposes. Purpose one is if they come in with a baggie with 3 hairs in it every single day and they're complaining of hair loss, you can say, I lose more than you do. Take the bag in front of them, throw it in the garbage can, and say, go away. All right, that's one. On the other hand, if they bring you in a baggie that's just loaded with hair, it looks like you could make a little mini rug with it, then you have to worry. This is a serious problem. And then 2B is you can actually look at the hair. What kind of hair are they losing? Is it growing hair? Is it resting hair? Is it the hair that looks like hair shafts in alopecia areata. I'll show you pictures in just a few seconds so you can actually get some useful information and you can sort of semi-quantitate it. Look at the hair. I just talked about this. Take a good history because everything from surgery to crash diets to stress to febrile illnesses can affect hair growth and you can actually have hair loss. Now, when there's an event, a sentinel event, death in the family, divorce, major surgery, postpartum, anything like that, usually the hair loss is delayed about 3 months. So take your history. You don't want to know what happened last week. You want to know what happened about 3 months to 4 months ago. And that's when their hair starts falling out. So history is important. The usual stuff for general medical review of systems, looking for diseases that can be associated with hair loss, things like lupus and so forth, and drugs. Drugs are important. I'm going to show you a fairly short list that can be associated with hair loss. And again, that hair loss is usually delayed about 3 months. So you got to know, not did they start a new drug that you didn't give it to them, because what you're giving is on the chart, you know, but it's what you or somebody else gave them 3 months ago or 4 months ago. They started the drug. Okay, so those are things you can do. And then exposure to heavy metals. Lots of ways to be exposed to heavy metals, certain industry exposures in particular. You know, the old eating the paint off the wall, full of lead exposed. There's some exposure. And I'll comment on that further in just a second. So here are the 3 types of hairs. There's actually a 4th, it's called catagen, but it's it's sort of in between growing and resting. It's kind of hard to illustrate, and you're not going to find many of those anyhow. So you see the anagen, that's growing hair, anagen. And you see it's covered with a sheath, and it's pretty large at the bottom, and that's what an anagen hair is compared to a telogen, which is the resting hair. That's sometimes also called a club hair. And if you pull a hair out and there's no sheath and it just has that little teeny tiny bulb at the bottom of it, that's a telogen hair. If you pull a hair out and it has that big sheath surrounding it, nice pigmentation and wide base, that's a growing hair, an anagen hair. So if they bring you a bag that's filled with 200 anagen hairs, that means they're losing growing hairs. Can anybody think, why would you lose hairs that are normally growing? What one big event? Chemotherapy. That's what kills growing hairs. Remember, what's chemotherapy designed to do? Kill the most rapidly dividing cells, which are presumably the cancer cells, but it also affects the oral mucosa in the hair for the same reason. Those cells turn over relatively rapidly, or those, in the case of hair, the hair, basically a hair matrix that's underneath it makes the hair. So what they have in their little bag is important. And then the last one are alopecia areata hairs. That's a very specific disease, but the hair is it's pathognomonic. If you see a bag full of those hairs, you got your diagnosis. End of story. Let's talk about therapy. And alopecia areata hairs narrow. They go from normal width, they get narrower and narrower and narrower. They start tapering down to almost nothing, and they lose their pigment at the bottom. So this is a nice picture of one. They bring you 300 hairs that all look like this. They have alopecia areata. It's an immune-mediated disease, and then you know what they've got, and you can treat them. So the 3 kind of hairs. The big watershed in hair loss is this. Remember with itching, what was the big watershed? Rash, no rash. So the big decision tree here is, are they having scarring alopecia or are they not? If it's scarring and you look on the head, if you don't know what looking on the scalp, what it should look like, you know, look at someone you don't mind going up to and saying, can I look at your scalp? And you'll see little pores, you'll see follicles, and in those little pores, those holes, you'll see hairs coming out. And those hair follicles should be distributed pretty much evenly all over the scalp. If you look at scalp like this, you see there are areas where there are no holes anymore. It's just slick, but not only is it slick, there's no hole. It's gone. That follicle is history. That's scarring alopecia. Why is that important? You're not going to regrow a hair there. No matter what you do, it's gone. There's nothing to grow from. But there's some process that's causing that you might be able to interfere with from a therapeutic standpoint to prevent progression of scarring alopecia. On the other hand, if you look at someone whose hair is thin and patches are all over the place, and even where they have no hair, they still have hair follicles. You can still see the little holes from which a hair should be growing. Then there's hope that you can grow their hair back. At least they still have a follicle. It isn't gone. And your therapy might be able to restore some semblance of normal hair density. The other reason, not just from a therapeutic standpoint, but very specific diseases fall in those two groups. And that's how we're going to do the discussion. Which ones are scarring alopecia, and then what sub-patterns, what other things can you see that lets you classify the disorders under those circumstances versus which ones are not scarring, and what characteristics will allow you to distinguish between the various causes. Because this is a complicated subject, if you can at least put them in a category to start with, you have a leg up. So you want to know, is it scarring or is it non-scarring? That's really number one. This is scarring because there are areas you see the follicles, you see hair, and then where that arrow is, there's no follicle, there ought to be, that's scarred, it's gone, it's bye-bye, but whatever process caused it, you want to try and interfere with in the future. So here are the causes of scarring alopecia. Kind of in frequency, not exactly, but pretty close. So exogenous things are the number one cause of scarring alopecia. What people do to their own hair and scalp. And I'll show you examples. Discoid lupus erythematosus, the thing speaks for itself. There's a very, I used to say uncommon, but I think it's becoming more common, or maybe we're just recognizing it, a very specific disease called centrifugal alopecia. Starts in the center and it works out, centrifugal. That's a scarring alopecia. Morphia can occur on the scalp. Lichen planopilaris is lichen planus of the scalp. Those purple polygonal papules that itch when they're on the wrists actually accumulate around the hair follicle, cause inflammation, and wipe the hair follicle out. Alopecia Neoplastica, that's cancer metastatic to the scalp. Number one cause is breast cancer. I'll show you examples of this. So what happens is the cancer just spreads through the dermis, spreads through the middle of the skin, killing hair follicles while it does. And you might expect, as you might expect, it's kind of like feeling this podium. It's rock hard. It's cancer. And then last, dissecting cellulitis, I'm not going to talk about. That's a subject that's an hour into itself. Okay, what can people do to themselves that are problems? They can use chemicals, they can use heat, they can pull their hair in a way that it shouldn't be because of the way of the nature of the hair. People who have curly, wavy, wiry kind of hair, when you start pulling it to make a ponytail, or you start putting it in little teeny tiny braids, putting pressure on it, hair doesn't like pressure. It gives up the ghost and it dies. The same thing if you augment that with chemicals, it's even worse. So let me show you some examples of that. So this is the most common. It's called traction alopecia. And you see it predominantly in the United States and African American women who use either chemicals or heat to straighten the hair and then pull the hair back. All of that is trauma to the hair and the hair follicle, and it dies. And so you have an area of alopecia, an area of hair loss. And that's going to look cicatricial. There'll be no pores there left anymore. What you do see still is this. Usually there's a little fringe in front of the alopecic area. And that's a clue that this was related to traction, sometimes augmented, made worse by chemicals and or heat. Look at the little girl there. She has these very, very tight braids. And her hair, which is normally curly, wavy, doesn't like that. And this pattern is repeated day in and day out. And so what happens is she starts having widening of her natural parts. What's going on in that widening area? Hair's dying. Now, she still has a lot of hair left, and probably it won't be grossly abnormal, but over time it will. Look at the adult woman who's there. She has pulled her hair into a little bun on the side, she said, all of her life. But what has she done? She's pulled it that way so much that now she has an entire area that is devoid of hair. You cannot regrow that. Nothing will regrow it because there are no follicles. You hope she has enough still that if she puts it down, it'll cover that baldish area. But, you know, that's from a lifelong habit. And it's very difficult to change lifelong habits. Trust me. Look at this girl. This was my patient. One benefit of being in practice, as many of you who are older know, is you follow patients over many years. Sometimes over many years, you can establish a relationship that allows you to change patterns like smoking or drinking. Sometimes you just can't. So I told this girl at age 14, please don't wear your hair this way. And no, you look beautiful, but you're pulling it back. You're putting it on pressure. You're using chemicals to straighten it, and you're going to have problems later. 14. She didn't listen. So she came in at 19. It's the same girl. And now look at her. You see that area up front? She's pulling it from the front to the back, and where she's putting traction on that hair, it's not happy. It died. So now she has a clear alopecia hair loss area. I said, please stop doing that. I told her years ago, don't do this. She continued to do it, and she came in 2 weeks before her wedding. And here's what she looks like. I can't fix that now. I couldn't fix it if I had 2 years. And that's from a lifelong habit of putting her hair on traction. You still see those little fringes in the front. That's a clue. It's related to traction, sometimes augmented by chemical or heat exposure, but it's mostly from traction. It isn't just, however, in African Americans. The original description of this entity was called Alopecia groenlandica. Groenlandica is from Greenland, because I've never been to Greenland, although if I go outside now, it's probably like Greenland. But in Greenland, apparently the people have very wiry, very curly hair. They like wearing little braidy things. And so after a while, you get to this, pulling the hair back, putting it on pressure, putting it on braids. And so you have the little fringe there and hair loss that's scarring behind it. So it's anybody who has sort of wiry, curly hair. You try and straighten it. You try and pull it back. It's not a healthy lifestyle. It just really isn't for your hair. Okay. Then there's central centrifugal alopecia. As I said, it starts in the center, it moves out. This is nearly 100% African American women. It's not going to be men of any ethnicity. We don't really know exactly what causes this. It might be related to dye, it might be heat, might be traction. We really don't know. The most recent papers show a clear association with type 2 diabetes. And this is scarring. And as this process expands, it's leaving scars behind it. I don't mean scars like you can see scars, but scarring of the follicles, so the follicles are gone. Hair transplant might be of some benefit. This is an extreme example. Whenever you see a list of treatments that's more than about 3 bullet points long, what do you know? No one treatment's very damn good. So we do this, we inject it with intralesional corticosteroids at 4 or 5 sometimes even a little higher milligrams per ml triamcinolone acetonide. You just raise a little bleb. You put the little blebs about an inch or so apart over the whole area that's lost hair. What are we doing? I have no idea. There's some inflammation if you look at this very early, so we're trying to cut down the inflammation, I guess. We use topical steroids, the same reason in a shampoo, cut down the inflammation. Biotin is an essential nutrient for the hair. Now, it doesn't really grow hair. It's not like putting nitrogen on a plant, but it does make the hair tensile strength better. So whatever hairs are there, we want them as strong as possible, so we give biotin. We use minoxidil, which we know is approved for the use in androgenetic alopecia, patterned hair loss, normal hair loss. Maybe it helps stimulate some hair growth. For whatever reason, it stimulates it in normal hair growth. We don't know. We encourage stopping using relaxers or heat or dyes or traction. And if it's stable, transplantation, and really the realistic goal is not very good. Maybe 10, 20, 25% regrowth at the most, if any, at the periphery that maybe you can comb over. It's a bad disease. This is how we treat it. It's not terribly common, although, as I said, I think we're recognizing it more. So in an African-American woman who complains of hair loss that started in the center and is moving out to the side fairly rapidly, you're not going to pull hairs out. They're not loose, but something's going on under that skin, under the skin of the scalp that's scarring those follicles away. Think about this entity, and honestly, send these to the dermatologist, because we're not going to do very good, but let us take the fall. You're not going to do any good either, and you need to keep good relations for other reasons, right? Discoid lupus is obvious when you have inflammatory disease like lupus erythematosus. It wipes out everything in its path, leaves scars, so it can leave scars on the scalp. Okay, this woman came in complaining of a patch of hair loss. And you can see she has a little patch of hair loss. You can also see a little bump in it. And touching this was rock hard. This is metastatic cancer to the scalp. Of all internal cancers, published in Southern Medical Journal by me, by the way, 5% will metastasize to the skin. Some more commonly than others, but it's uncommon. If they metastasize to the skin of the scalp, the cancer cells will grow, they will expand, and they will kill follicles. And that's called alopecia neoplastica. So you see an area, usually there's some erythema there. If you feel it, it's rock hard. There's no hair follicles because they've been wiped out by the cancer. And the most common is breast in women. So that accounts for well over 3/4 of alopecia neoplastica. But it can be lungs, cervix, desmoplastic malignant melanoma. It can be prostate in men. So you would do an appropriate workup. Now, if you biopsy this area, biopsying the scalp is kind of a bloody mess, but not with cicatricial alopecia because it's scarred. It's not only wiped out the hair follicles, it's wiped out some of the blood vessels, so it doesn't bleed as much as normally if you biopsy on the scalp, which bleeds a lot. You got to be ready. You have to close these things with a suture, but not with this one. If you biopsy that, sometimes the pattern of the underlying cancer is maintained. So sending the specimen off, the pathologist can tell you, this is metastatic bronchogenic carcinoma, this is metastatic prostate carcinoma, this is metastatic whatever. Sometimes it gets lost in all the scar tissue, and all they can tell you is it's metastatic cancer, and then you have to go search for it. Okay, let's talk about non-scarring hair loss, which is much more common. And again, the most common is androgenetic alopecia. Why do we say that? Androgens, because androgens are responsible. The receptors on the hair follicles that accept androgenic stimuli are responsible for growing the hair as a fetus and an infant and a toddler and an adolescent. The same receptors later in life, and no one's figured out why, turn on us. So androgens attaching to the same receptors that made the hair grow make the hair follicle miniaturize. It gets smaller and smaller, so it makes smaller and smaller, and tinier and less perceptive hair. It's not that someone who's bald doesn't have hair. They have miniature little, if you look up close with a magnifying lens, because their follicles have miniaturized due to androgens. It's the same thing in men and women. The pattern is a little different, as I'll show you, but it's the same pathogenesis, by far and away the most common. People who lose, and that's sort of a gradual process, as you know. People who lose massive amounts of hair, they're going to bring you a baggie with 200, 300 hairs in it. That's called an effluvium. That's what it's called. There's an anagen effluvium, growing hairs being lost in large numbers. We've already talked about that. That's chemotherapy mostly. And then there's telogen effluvium, where they're resting hairs. About 10 to 15% of the hairs at any one time are resting. Those account for the ones that come out every day as a normal process. But if all of a sudden, all the hairs, or a lot of the hairs that should be growing, suddenly become resting, and those don't stick very well in the scalp, so they're going to come out in droves. So that's a telogen effluvium, resting hair loss in large numbers. Alopecia areata is immunologic. A few medical things. Iron is an essential growth nutrient for hairs. So if someone's iron deficient, they may start losing hair. And I've seen fairly substantial hair loss in young people, mostly young women who don't eat a lot of meat, they don't take vitamin supplements, they're losing iron every time they have a menstrual period. And they have fairly substantial hair loss. And interestingly, because they're young and otherwise pretty healthy, they don't say, I can't walk up a flight of stairs without stopping to, huff and puff. So yes, iron deficiency can present as hair loss. Also, thyroid dysfunction, hyper or hypothyroid, can present as hair loss. Secondary syphilis. Hair loss can be the only manifestation or one of several manifestations of secondary syphilis. We'll talk more about that in a second. Tinea Capitis is a kidney disease. It's fungal. And then Trichotillomania. You could call them trichotillomaniacs. They pull out their own hair. And if you do that repeatedly, eventually, it's no longer non-scarring. It starts so traumatic, it starts to scar, and you can't regrow the hair. So we'll talk about all of these. So there's androgenetic. It's programmed. It's driven by androgens. It's more frequent in men than in women. It's more pronounced in men than in women, but it happens in both genders. We have 2 therapeutic options approved by the FDA. Topical minoxidil and brand Rogaine, but Walgreens has its own brand, CVS has its own brand, or systemic finasteride, Propecia, brand name, it's 1 milligram. It's expensive. You can take a generic 5 milligram tablet and have someone cut it into 4. Okay, well, that's not exactly 1 milligram, but it's close enough. Saves money. And the pattern is different. In men, it's at the vertex and bitemporal, starts receding hairline. In women, it's the central part where this starts, and then the central part just gets wider. It's not scarring. You can still see hair follicles, but they get thinner and thinner and thinner and thinner from the center out. Same process, but it manifests slightly differently. So here are some examples of mild to moderate to severe programmed normal balding hair loss in women. And you see how that process starts in the center and just moves out. If you have patches, little round patches of hair loss all throughout the scalp, that's not normal. That's not a normal pattern at all, ever. And for men, this is sort of the extreme example of bitemporal loss. So it's receded and the vertex hair loss is gone. And the one gentleman who has almost nothing left was really concerned about his hair loss. I said, now? Like, now? And I could do that because we're good friends and we've known each other. He's an infectious disease doc who's been my friend and co-author on papers for 35 years. Now you talk to me about it? So minoxidil. Minoxidil comes in 2 and 5%. In women, the 2 and the 5% work about the same. The 2% is usually the women's version, 5% is the men's version. But honestly, I use the 5% in everybody. Let me tell you something. You're not going to turn anybody into Don King by using the 5% minoxidil. I don't care if they drink it or infuse it into their scalp. What you hope to do is stop or retard the progress of their ongoing natural hair loss and maybe regrow something. You're not going to regrow everything. It just doesn't happen, very rarely. Finasteride is the same thing. And what does finasteride do? You know, think about it for benign prostatic hypertrophy, right, when you're taking the bigger dose. Finasteride blocks the conversion of testosterone into its active form, so it can't then, therefore, bind to its normal receptor. So it actually works better for men than women. It's approved for men, not for women. But here's a clue. For women who are having relatively rapid progression of their normal pattern hair loss, finasteride does work, but you have to give higher doses, 2.5, 5 milligrams a day. For some women, that's worth a try. You're going to have to do a little dance when insurance says, why are you giving a prostate hypertrophy drug to Mary Jones? Well, she has a prostate. I don't know. But sometimes it slides right through and no one questions it. I think it actually works reasonably well in some women. There's no way to predict. There's no blood test to get in advance to know, oh, this one it'll work on, this one it won't work on, and so forth and so on. But these are your 2 approved things you can do. Be very careful about scams. This is the AccuBrush for $14. Applying therapeutic acupuncture to the scalp to grow hair was the advertisement. Bullshit. This is useless. It's $14 in some scam artist's pocket. Now, here's the other thing, which appears to be a scam, but may actually not be. And that's low-level light therapy. It's red light, visible red light. Usually there's a diode that's emitting this. Those are very long, so they don't burn out like a light bulb does. They're small ones, and this comes in all fashions. It comes as a comb, it comes as a helmet you can wear, it comes as a thing you strap on, kind of like a bonnet, and it's approved by the FDA as a device. What that means is it's safe. They don't say anything about efficacy. They're talking about safety. They're expensive, so if someone's choosing between food and this, I would tell them to do food. But if you have a patient who can afford $300, $400, $500, $600, $700, and they're losing their hair and they want to try it, there actually are a couple studies done by hair gurus, experts, that show this does, over time, help to regrow hair from normal, natural hair loss. I know it looks, yeah, right, that's going to work. You look at that picture, you think, no way, brushing this through your hair. But there actually are studies that show it does. The difference is when the study shows an increased density of hair follicles, and you're looking at 1 square inch, and you see a few more hair follicles than there were before, does that translate into cosmetic benefit? Does it actually look better, or can you measure a few more hairs? So what? And so you just look at this and you think, oh, that's so hokey. But if you look, these are examples that the companies who make these things have put out, and a couple of them where I put the arrows are actually pretty impressive. And I will tell you, I'm in Houston, so when oil prices are up, I have lots of rich people that I see, and I have people that can afford this. They don't care. It's not going to be covered by anybody's insurance, trust me. And I've had people who actually did cosmetically improve the appearance of their hair. And then I've had people that nothing much happened. So I think it's a crapshoot. But there is scientific literature by well-known hair experts saying that this does stand a chance to work. So while it looks like a scam, it may not be, and it may be efficacious as long as they're still taking their medicine and eating food and not trading it for this. I mean, you look at that, it's not perfect, but you look at the center of her scalp, and clearly that central part looks better. depending on how she styles her hair, she takes it from one side and puts it over, or sort of semi puts it over, that's enough improvement to hide the alopecia she does have. And there's no contraindication, by the way, to combining low-level light therapy with finasteride or with minoxidil. Okay, massive hair loss. Anagen Effluvium first. This is the, oh my God, where are all these hairs coming from picture. And so that's 1 day's hair loss you see above. So that's obviously not normal, right? You pull, you get lots and lots of hair because we have a lot of anagen hairs. 85% or so are ingrowing. You pull, they're all coming out. Why? Chemotherapy. Second thing is heavy metal toxicity, exposure to arsenic, lead, and thallium. These are used in all sorts of manufacturing processes. You have to know what kind of job. Do they work in smelting, where you're extracting ores? You can be exposed to this. It becomes vaporized. The other thing is, let's say they're not having chemotherapy and they work as an accountant and they have an Anagen Effluvium. Somebody's poisoning them, because one of the other things that can do this is arsenic. I literally have been involved in 2 murder trials, attempted murder trials, where people were poisoning their significant others. Thallium used to be in rat poison. It's taken out, but you can still get it online. And someone, Googles, kill my husband, and you find arsenic or thallium, then you find somewhere to buy it, because you can buy anything online now. You can buy an F-16 fighter jet, probably a small nuclear device, I don't know, eBay and Amazon. So they find places to get these things and they start putting them in the food a little bit at a time. It's just like the Borgias. I mean, it's incredible. But yes, heavy metals can cause massive loss of growing hairs. And if they're not getting chemotherapy and they're not involved in some industrial process, you have to worry about poisoning. And it's usually a spouse. Call the cops. Okay, it's interesting. I don't remember this list. I actually have this list printed out, because what will happen, and of course they have an oncologist, but if someone's getting chemotherapy, their number one concern is, am I going to lose hair? They're really concerned. How nauseated will I get? How sick will I get? Will I lose my hair? Some chemotherapeutic agents, like capecitabine, which is Xeloda, it's commonly used to treat colon cancer, stomach cancer and stuff, it doesn't cause much hair loss. And some things, you take 1 dose and your hair's falling on the floor. So this is a list stratifying chemotherapeutic agents in high risk, medium risk, and very low risk. Now, they'll probably ask their oncologist, but then, sometimes they don't trust the oncologist, or sometimes they've known you for a longer time because you're delivering their primary care, and they'll come tell you, I was diagnosed with cancer. Maybe you diagnosed them with cancer. You sent them to the oncologist. The oncologists, is there any oncologists in the room? They have a kind of funny personality. They don't want to get close to their patients because many of their patients are going to die. And so they're like this. And you have more empathy with your patients because you're taking care of them for whatever, or you've known their whole family, et cetera, et cetera. And they may come ask you. So it's not, I would print this out, tuck it somewhere where you have some easy accessible references. So if your patient comes and asks you, am I going to lose all my hair? I'm getting chemotherapy. What kind of chemotherapy? What are you getting? They'll find out, or they'll know, or they'll have it written down, and you can compare it with this very accurate list of high risk, medium risk, and low risk in terms of hair loss and chemotherapy. Okay, there is a new device I want you all to be aware of. It's called the DigniCap. It's for dignity. You put it on a half hour before, during, and then an hour or 2 after chemotherapy. It reduces, because it's cold, it reduces the blood flow to the scalp, and it protects the scalp from the systemic infusion of chemotherapy. It's been used in Europe for a very, very long time. It was just approved in the United States here recently. And people retain their hair, and it's a good thing. The only situation, however, in the US that it's approved for is breast cancer, both the major chemotherapeutic regimens for breast cancer. But some kinder oncologists will use it off-label for other chemotherapeutic infusions that involve agents that have high risk of hair loss. Some oncologists, interestingly, don't know about it, which I find rather interesting, or maybe they just don't want to deal with it. So you should know it exists. You can recommend to your patient who comes to tell you, I have cancer, or you know already, and I'm going to have chemotherapy, and am I going to lose my hair? Listen, ask your oncologist about the DignaCap cooling device. So just to give you an example, this woman should have lost every bit of her hair from her breast cancer therapy, but that's her using the device, and that's acceptable, right? Compared to no hair at all. So this is a real advance in our ability to help people. I've seen my daughter and my wife go through chemotherapy, and it's brutal. You know it's brutal. And everything you can do to help soften the blow. Losing your hair is a blow to the dignity of the person, is an advance as far as I'm concerned. Telogen effluvium, this is the opposite. Now, you're not the growing hairs, they're the resting hairs coming out. It's usually an acute event, postpartum illness, post-op, major surgery, not having a tooth pulled, but having a diabetic toe amputated, or major abdominal surgery, or whatever. Psychic stress, divorce, death, major psychic stress. And then drug-induced, and I've listed the drugs there. Notice one of them there is the most commonly prescribed beta blocker in, I think, the world, metoprolol, can cause hair loss. This is reversible. If you take away the inciting thing, or the inciting thing's over, then it often will stabilize. They'll lose hair a lot for 3 to 4 months, then it'll stabilize for 3 to 6 months, and then it'll start to regrow. But remember, it usually starts about 3 months after whatever it is. And then the whole thing takes about a year, the whole process. There's really no thing you can do that uniformly helps speed this up. Sometimes topical steroids help. Sometimes oral spironolactone, figure that one out, in low doses, 50, 100 milligrams a day. Oh, and by the way, people aren't going to get hyperkalemic and die if they take spironolactone and eat a banana. It's really never been reported. It's everybody worried about it because you retain potassium. It's really a pretty safe drug. The bigger problem, particularly in women, is enlargement of the breast, but not just enlargement, but painful enlargement, or if they're still having menstrual periods, irregularity, spotting and bleeding and stuff. But it's a pretty safe drug to use. Sometimes that helps, but most of the time, telogen effluvium, you just have to make sure whatever it is over, or the drug that caused it is withdrawn. And this is just one example from my practice. This is postpartum effluvium. So 3 months after she had a baby, happy mother, happy baby, happy husband, and her hair's all gone, and she's sitting there crying, literally, totally devastated. And I would be too. But look at what she looked like 9 months later, without my lifting a finger, with my just counseling her that this is going to regrow, almost always completely. Now, one more thing. Look at her hair. That's not a perm. Her hair went from kind of straight to quite curly. When hair regrows from any of the diseases we've talked about or we'll finish talking about, it often changes its texture. It can go from straight to curly, curly to straight. And regrowing hair, no matter the age of the patient, can sometimes regrow gray. Even they weren't using color, it was still fine, normal color. It can regrow as if they're 40 years older. So both of those things can happen. Alopecia areata is an autoimmune disease. It's somewhat familial. It affects 4 million Americans. This can affect the hair anywhere. So it can be scalp, eyebrows, eyelashes, beard hair, chest hair, pubic hair, all the hair. Alopecia totalis is all the scalp hair. Most of this is on the scalp, but anywhere it can be affected. Alopecia universalis is loss of all the hair. This does best when it's treated young age, when it first starts and when it's not too extensive. When all the hair is gone and someone's 50 and they've had it 40 years, you're not going to regrow their hair. It's not going to happen. Don't waste your time. Don't waste energy. Don't waste the patient's money. But early, if you catch it early, you can usually put a stop to it and they'll regrow. And when they do so, most of them will do so within a few years. Okay, it's an autoimmune disease, so it's associated with other autoimmune diseases like pernicious anemia, like autoimmune thyroid disease. There often are thyroid autoantibodies involved here, which may be then associated with thyroid dysfunction, not just a blood test, but actual dysfunction. And they may also get vitiligo, which is an autoimmune attack against the pigment-making cells. This is not a happy disease. It's been described since 400 BC. This is an old disease, well described. But these are patches of it. I will tell you the worst area to try and regrow, the most difficult, is right behind the ears, across the back. So that area is particularly hard to regrow. But if it's all over the center of the scalp, it usually is reasonably easy. So these are mild cases, but then you get like this. And that's devastating to a person. This is actually Humira, just to let you know, because you all are using biologic drugs like Humira. Humira is a great drug. Psoriasis and ankylosing spondylitis and inflammatory bowel disease, psoriatic arthritis. You know all these indications. A great drug, a workhorse drug, pretty non-toxic drug, but it can cause hair loss. Alopecia areata actually is what it is histologically and by the kind of hairs that are lost. So how do we treat it? It's steroids, steroids, and more steroids, but try and avoid systemic steroids. Systemic steroids will reverse the process. They'll regrow the hair as soon as you stop the systemic steroids because they now have high blood pressure or glaucoma or cataracts or gastritis or bleeding ulcers or tuberculosis, or they just look like Alvin the Chipmunk. The hair will all fall out. So don't give systemic steroids, but intralesional steroids and topical steroids actually can do the trick, and the take is better. Topical minoxidil, again, we don't know why it would work in an autoimmune disease, but it also is helpful. Topical tar derivatives like anthralin, unbelievably irritating, but they can regrow hair in alopecia areata. Have to be careful about using them though, because they're irritating. Excimer laser, PUVA light therapy, cyclosporin. I think one of the interesting things is in Japan, I like reading the foreign derm literature because sometimes they do things that seem a little odd, but they work. In Japan, they treat alopecia areata with fexofenadine. That's Allegra. Why would that work? Are there mast cells involved? Is histamine elevated? No. But for some reason, it seems to work. By accepted evidence-based criteria, nothing works. I mean, Cochrane analysis, nothing works, but they do work. So this is the first patient after I read that, and there are a whole bunch of, about a half dozen papers in the recent Japanese literature. I treated, she had rapidly expanding alopecia areata. Notice how it's in little patches. They're slick. If you pull hairs at the periphery, they'll look like the alopecia areata hairs, but they'll still have hair follicles. So she was the first one I said, okay, I'm going to try fexofenadine in this patient. No way it's going to work. She regrew every stick of hair. Would she have done it normally? Could the process have? Absolutely. So then I tried it on my next 6 consecutive alopecia areata patients. 5 out of the 6 regrew hair. How much safer can you get than that? How much cheaper can you get than that? So just think about it, try it. Maybe my next 25 it won't work, but who knows? The Japanese swear by it. And I have a son who lives in Japan, so I go to Japan as much as I can. I try and get a talk so they'll pay my way there. But so I know a lot of the Japanese dermatologists, they swear by it.
How long do you keep them on?
They regrow, and then I keep them on 3 months afterwards. I don't know if that's optimal, but that's what they do in Japan, so that's what I do. Okay, iron deficiency. Iron deficiency. Don't just get a CBC. What if you have a young woman who's had menstrual periods. She comes in and she's got a hemoglobin of 12. That's 12.3. That's acceptable. But she could still be iron deficient, even though her H and H are okay for her age and gender. So you have to really check iron or ferritin. You have to find out what's going on. You replete their iron, and their hair comes back. Kind of interesting. Thyroid, I already mentioned, hyper and hypothyroid. I'm not going to talk about thyroid measurements. Hopefully someone else will be talking about thyroid. We have our wonderful endocrinologist. But at least a TSH is a good screen. By the time they've lost hair, and that's their complaint, usually their TSH is abnormal. So you'll know that way. This is a hypothyroid. She came in because she looked like this. Okay, fine. Part of the screen is iron, part of the screen is TSH. Her TSH was abnormal. She's hypothyroid. TSH was off the chart. I said, do you have intolerance of cold? Yes. You know, I mean, she had all the, do you have dry skin? Yes. But what she came in was for her hair. This person has a thyroid disorder. Does anybody have any idea what this person might have? Graves, right? Graves' disease. So not only might they lose hair, but another interesting thing that can happen is their nails start peeling off the nail bed. So they have what's called onycholysis. So there's this big space between the nail and the nail bed, and dirt can accumulate under there. So hyperthyroidism. Syphilis. Syphilis has made a major resurgence. We now have in the United States more cases of infectious primary and secondary syphilis than we've had since 1995. And the statistics, I think I have the statistics in here. Yeah, okay, I'll get to there in a second. So this may be the only sign. It's called moth-eaten alopecia. It looks like a moth was chewing. So if you have the whole scalp bald, it's not syphilis. It'll be patches of non-scarring alopecia. You can still see the hair follicles. Okay, the statistics. This is 2014. 2015 came out after I sent my talk, so I don't have time really to change it. So Nevada is not #1 anymore. Anybody here from Louisiana? Congratulations, y'all are the most syphilitic state in America. Anybody here from Georgia? You're #2. So we're back on top. And typically, it's the same states, they just juggle around a lot. And if you look at this list, where are you likely to see syphilis? Southern Medical Association. There you go. And if you look at the cities, New Orleans, Miami, Tampa, Raleigh, I just have to do this. Columbus, Ohio. Last 2014 and 2015 in the top 10 syphilitic cities in America. That's where the Ohio State University is, and for obvious reasons, I'm proud to say that. Columbus, Ohio is a syphilitic city, not Ann Arbor, Michigan. Syphilis still responds to benzathine penicillin, and if they have hair loss, every stick of hair will regrow. Tinea Capitis, this is a kitty disease. Mostly younger kitties, major metropolitan areas most commonly. Adults can get fungal infection of the scalp, but they're immunocompromised or immunosuppressed. What does Tinea Capitis look like? You have an area of hair loss, and most of the time what the fungus has done is it's eaten the hair. The keratin, the major structural protein of hair, is food for the fungus. So it eats the hair gets weakened, and it breaks off right at the scalp surface. So you see little black dots, the remnants of the hairs. Sometimes you see a gray patch because there's scaling there too, because fungi actually, the dermatophytic fungi like T. rubrum, T. tonsurans, they induce scaling. And if it's a fungus due to an animal, which can cause Tinea Capitis, or one that's a plants or dirt, instead of it being sort of a symbiotic fungus, it causes a very inflammatory, boggy, full of pus, lumpy, bumpy hair loss. That's called a carrion. But by far and away, the top two pictures are what you would see in the US. Almost all Tinea Capitis in the US, vast majority, is a single organism, Trichophyton tonsurans. And that's changed dramatically from when many of you and I trained, it was Microsporum audwinia. It's a totally different species of fungus. There's an important point I just want to make here. If you take care of kids, you see hair loss, you think it's fungus, you go to your textbook, if you don't already know what to do, and it says, shine a woods lamp on it, it'll turn green. Waste of time. Microsporum turns green. Trichophyton doesn't turn green, it doesn't fluoresce. So since the predominant organism, 98% of all Tinea Capitis doesn't fluoresce, using that as a diagnostic tool, the woods lamp is faulty. And this can be treated, again, I don't want to go over this, it's in your handout, griseofulvin or terbinafine, appropriately treated with one or either one of these, to skip that. Terbinafine and griseofulvin actually should be continued a little bit after the hair started to regrow, and all of this should regrow. Okay, home stretch, trichotillomania, people plucking their hair out. Why do they do this? Because it's easier when you're under stress to pluck your hair out than reach inside your abdomen and take out your spleen. Okay? So they do this. And what do? You pull some hair out now, a couple weeks later you're stressed again, so you pull out some hair. It starts to regrow. So what you see are areas of alopecia with some regrowth with hairs of differing lengths because they didn't pull it all out simultaneously. And remember when I talked about N-acetylcysteine as a treatment for prurigo nodularis, which is another sort of I'm crazy, I'm pulling, plucking at my skin. These are pulling, plucking at their hair. It works for that too. N-acetylcysteine is probably the best drug for this all told. So this is what you see, hair regrowing after it's been plucked out. It's at different lengths. Why do they do this aside from being crazy? They might be malingering. They don't want to go to school or work. They might be suing someone. I've had some people do this and then try and sue, Johnson & Johnson because it's the shampoo, it's toxic. They're neurotic, they're psychotic, they're obsessive compulsive. I'm not much of a mental health care provider, but I see this, I try and get them to go to someone who knows what they're doing for mental health. This is N-acetylcysteine, regrowing the hair because it suppresses the nerve urge to pluck. That's it. They just leave their hair alone and it regrows. Okay, now this is my ultimate in alopecia. Not only did she lose her hair, she lost her scalp. And now she's down to the galea. I don't know how she wasn't dead, but she walked in like this to my office at the university. And I couldn't help myself. I said, oh my God. And I don't usually say that even with horrible looking rashes, but this was an oh my God. And she said, I had to get the aliens out of my brain. Okay, so I sent her immediately to her primary care. No, I called up my favorite psychiatrist and I said, I'm sending you a woman right now. My nurse is walking her over to you because I'm not going to deal with this one. And then I just wanted to put in one slide, this is not hair loss, this is hair gain. It's called Hypertrichosis Lanuginosa. It's lanugo hair, the fine hair that babies have all over the face. There aren't a whole lot of cases of this, but I wanted to put it in because it's absolutely pathognomonic. They have cancer. If you see this, they've got cancer somewhere, lung, colon, prostate, somewhere. It's not terminal hair, it's fine hair. More common in women than in men. But if you see that, where they're growing this fine hair from nowhere, you need to do the appropriate history and physical as if you're screening them for cancer because they've got cancer. It's virtually 100%. So this is too much hair, the wrong kind of hair, and they got cancer. Look at you see the hair on the nose? You see that? So here's my last slide. Here's the patient saying, doctor, my hair's falling out. Can you give me something to keep it in? The doctor says, sure, here's a paper bag. So I hope we can do better than that now, thanks to my lecture, and thank you so much for your kind attention.